Hello and good day to wherever you are listening to us today. It is Friday, 7 May 2021. My name is Christian Littmeier and I'm welcoming you to today's global COVID-19 press conference with a focus on the new WHO Council on the Economics of Health for All. For this, we have a very special guest today. I'm happy to welcome Professor Mariana Masukato, the chair of the WHO Council on the Economics for Health for All, and professor in the Economics of Innovation and Public Value at the University College in London, and founding director of the UCL. Welcome. We have also a very special situation today because many of you have been waiting for the outcome of the TAG EUL and the SAGE deliberations. So we have guests for this too. We have the chair of the TAG, Professor Arnaud Didier-Laurent, with us, and Professor Alejandro Cravioto, the chair of the SAGE, for any further discussions later. But first, of course, here in the room, we have Dr. Tedros Adhanom Ghebreyesus, WHO Director General, Dr. Mike Ryan, Executive Director of WHO's Health Emergencies Program, Dr. Maria Van Kerkhove, Technical Lead on COVID-19, Dr. Soumya Swaminathan, Chief Scientist, Dr. Mariangela Simão, Assistant Director General for Access to Medicines and Health Products, and Dr. Bruce Aylward, Special Advisor to the Director General and the lead on the ACT Accelerator. Now, let me hand over to the Director General for the opening remarks. Dr. Tedros, the floor is yours.
Thank you, Christian. Good morning, good afternoon, and good evening. Wednesday's announcement by the United States of America that it will support a temporary waiver of intellectual property protections for COVID-19 vaccines is a significant statement of solidarity and support for vaccine equity. I know that this is not a politically easy thing to do, so I very much appreciate the leadership of the United States, and we urge other countries to follow their example. I also want to emphasize that WHO values the incredible contribution of the private sector to the pandemic and to health in general. We would not have the vaccines, medicines, diagnostics, and devices that save lives and improve well-being around the world if it were not for the innovation of the private sector. WHO supports companies making a fair return on their investment in research and development for investment in further innovation. We are in an unprecedented crisis that requires unprecedented action. Cases are at a record high. Almost 100,000 people are dying globally each week. And we have a chronic vaccine crisis. The World Trade Organization provisions for IP waivers were designed precisely for a situation like this. If we don't use them now, then when? It's also important to remember that intellectual property waivers will need to be accompanied by transfer of technology and know-how for this difficult-to-make vaccines. We continue to encourage all member states to support technology transfers through CTAP, the COVID-19 Technology Access Pool. We encourage governments to offer incentives to manufacturers to share technology and know-how. And we encourage countries with the most vaccines to donate doses through COVAX, which is the fastest and most equitable way to increase the distribution of vaccines globally. Just as it takes a comprehensive approach of public health measures to defeat COVID-19, so solving the vaccine crisis requires that we pull out all the stops. WHO is continuing to explore every avenue for increasing access to vaccines globally. This afternoon, WHO gave emergency use listing to Sinopharm Beijing's COVID-19 vaccine, making it the 6th vaccine to receive WHO validation for safety, efficacy, and quality. This expands the list of vaccines that COVAX can buy and gives countries confidence to expedite their own regulatory approval and to import and administer a vaccine. The Strategic Advisory Group of Experts on Immunization, or SAGE, has also reviewed the available data and recommends the vaccine for adults 18 years and older with a 2-dose schedule. Vaccines remain a vital tool. But right now, the volume and distribution of vaccines is insufficient to end the pandemic. Without the sustained and tailored application of public health measures that we know work. The COVID-19 pandemic is a vivid demonstration that health crisis is not just a health crisis. It can have dramatic consequences for livelihoods, businesses, and economies. The pandemic has shown that when health is at risk, everything is at risk. But when health is protected and promoted, individuals, families, communities, economies, and nations can thrive. That's why universal health coverage is WHO's top priority. All roads should lead to universal health coverage. I repeat, all roads should lead to universal health coverage. But globally, we're going in the wrong direction. Around the world, more households are spending an increasing proportion of their income on health. And more people are being exposed to poverty as a result of out-of-pocket health spending. It's clear that making progress toward this universal health coverage cannot just be a matter for ministries of health, but takes an all-of-government approach with leadership from the highest political levels and close engagement with ministries of finance. As we recover and rebuild, we have a unique moment to mobilize investments for healthier, more resilient, more productive, and more sustainable societies. We need a new narrative that makes health for all the central goal of public policies on innovation, industry, employment, environment, and more. That's why we have established a new WHO Council on the Economics of Health for All to identify new ways to shape the global economy and to build societies that are healthy, inclusive, equitable, and sustainable. The Council comprises 11 distinguished experts in economics, health, government, finance, and development from around the world, and is chaired by Professor Mariana Masukato, the professor of the Economics of Innovation and Public Value, and founding director of the Institute for Innovation and Public Purpose at University College, London. Professor Masukato, thank you for your leadership of this new council, and thank you for joining us today, and you have the floor.
Thank you, Dr. Tedros. I cannot tell you what an honor it's been also talking to you in the last months about this council, and it was so wonderful yesterday when we met for the first time with the 11 women. And as you and I have said, when people ask us why only women, we will say why not. So I'm already preempting one of the questions. The mission of the Council is to provide a new approach to shape the economy with the objective of building healthy societies that are just, inclusive, equitable, and sustainable. And fundamentally, what we want to do is reverse the usual logic. So what's the usual logic? The usual logic says invest in health because it's good for the economy. And we also find relationships between health and economic growth. We want to be much more bold and provocative than that. We want to say, focus on the goal. The goal is health for all. And for all the reasons that Dr. Tedros just explained, why that's crucial. And then we backtrack and understand how to restructure the economy. What does that mean? New financing tools, new types of public-private relationships. The private sector, of course, is important. So crowding in the private sector in fundamental areas that are critical for health for all. New ways to think about the debt and the deficit. So we're not always, asking very siloed questions, but also new ways to structure our budgets. So outcomes-based budgeting, outcomes being health for all. So we really want to unpick the economy, our economic structures in order to deliver on that goal. And to do that, I think the really important point that Dr. Tedros mentioned is the narrative. Where does innovation come from? Where do healthy societies come from? To do that, we really need to unpick the notions of value and of wealth and innovation, which again have often been very siloed. There's going to be 4 major areas of work, and maybe I'll just touch on them very quickly. One is on measurement. How do we actually value and measure health for all? And that means both within organizations, but also, of course, with GDP metrics, which we all know are limited. But unfortunately, we have not succeeded in really replacing the kind of static notions of, say, cost-benefit analysis and net present value as, again, kind of static ways to actually measure the value that, for example, ambitious policies can deliver. We want to focus on capacity on the ground, which we've, of course, with COVID-19 seen has really been missing in so many different countries. So what is the capacity within the public sector that's required in order also to collaborate with the private sector on all sorts of different areas? And unfortunately, as we have been under-financing, under-resourcing, but also under-imagining the role that the public sector can play, we want to really focus a lot on that. Third, finance. So the actual investment that's required in health for all. And that has 2 sides, both the financing, literally new financing tools, including how to redesign particular institutions like development banks to really also focus on health for all, but also the kind of macroeconomic finance, again, coming back to these issues of deficits, debts, and outcomes-based budgeting. And finally, innovation, which is so central to the topic this week and last week around the big news from the Biden administration in terms of how do we actually govern innovation, including not only intellectual property rights, towards areas that we're sure will actually benefit people, right? So innovation for the common interest. And of course, we need to be incentivizing innovation and think of all sorts of issues that are critical for the private sector, but really this is about nurturing collective intelligence. The private sector is very important, but so is the public sector in innovation. In the US, where Biden is leading the country, the public sector puts $40 billion a year in health innovation. So they are also creating value, co-creating value. So how can we actually govern that collective creation of innovation in such a way that people actually benefit? So these are the 4 areas, and I think I've spoken enough. So I'm happy to pass back to Dr. Tedros and happy to also answer any questions later.
Thank you so much, Mariana. Thank you, Professor Masukato. And I very much look forward to the Council's work in the months and years ahead, and look forward to working with you very closely. And thank you so much for your leadership.
Thank you.
Finally, Wednesday marked the International Day of the Midwife. To mark the day, WHO, the UN Population Fund, the International Confederation of Midwives, and other partners published the 2021 State of the World's Midwifery Report, which shows that the world currently faces a shortage of 900,000 midwives. Fully investing in midwives by 2035 would avert roughly 2/3 of maternal and newborn deaths and stillbirths, saving 4.3 million lives per year. Midwives are not a cost. They're an investment in a healthier, safer, fairer future for all of us. Christian, back to you.
Thank you so much, Dr. Tedros. With this, we're opening the floor for questions. And again, let me remind you that we have, as other special guests, also Professor Arnaud Didier-Laurent from the chair of the Technical Advisory Group, and Professor Alejandro Gaviotto, the chair of the SAGE. And in order to get into the queue, please raise your hand. And we'll start with Emma Farge from Reuters. Emma, please unmute yourself.
Good afternoon. Thanks for taking my question. I was wondering, 2 months away from the Olympics, is there any safe way for it to happen? Thank you.
Thank you very much. We'll start with Dr. Van Kerkhoff.
Yeah, I'll start, and others may want to come in. You know, the question of sort of, you asked a very specific question. I'm going to give you a very vague answer. There are a lot of things that are happening right now globally where we're seeing an increase in cases around the world. We have reached the highest level of case incidence. The number of deaths that are being reported around the world is really shocking this late into a pandemic. When we have the tools at hand that can prevent infections, that can prevent those who are infected from spreading to others, and can prevent people from dying. One of the biggest ways in which we know can limit the spread is around our physical distancing and reducing the number of contacts that we have. Having said that, what we advise in every situation is taking a risk-based approach, because the situation globally is very different. The intensity of transmission is very different. And so at an individual level, we're asking everyone to know what your risk is through that activity and take measures to lower your risk. Practice your physical distancing, wearing a mask, avoid crowded spaces, make sure you have good ventilation if you're indoors. It's as simple as opening the windows if it's safe to do so. Practice respiratory etiquette, get a vaccine when it's your turn. Avoid mass gatherings, and when there are events that are taking place, we support countries in using this risk-based approach to take the decision about if an event can happen. This is for the Olympics, as well as for having a barbecue in your home. Don't forget that even though there's a lot of attention for big gatherings like the Olympics, like religious festivals, like political rallies, there's also a risk at even some of these small gatherings at your home. It depends on where you live. It depends on how much virus is circulating. It depends on if there are appropriate measures that could be put in place to have a plan for case detection, for early recognition, for caring of those individuals, for contact tracing, a good communication plan. It also matters about the vaccine allocation and vaccine rollout in individual countries. So my answer is vague because it matters for every single event, every single gathering that is happening worldwide right now. What we really need is everyone around the world to take measures to keep yourself safe, to minimize exposure to this virus and the virus variants, and make sure that you don't allow the virus to spread. Mike?
Thank you, Maria. Now with specific reference, I think you were speaking specifically about the Olympics. The issues regarding the Olympics are multi-dimensional. There is the issue with regard to the safety of athletes and their teams within the environment of the Olympic Village and the Olympics themselves. Then there's the issue of the venues and whether spectators attend or don't attend. Then there's the issue of social mixing around those venues. And then there is the issue of whether spectators or attendees will come as from outside the country. And all of those have to be considered separately. It's not whether we will have an Olympics or not. It's how those individual risks within that framework are being managed. There's been a tremendous amount of work done on the playbooks for the teams and the delegations that are coming. A lot of preparation amongst those teams regarding testing and quarantines and arrival, and measures that have been taken in the Olympic villages, in the training facilities and around the venues themselves. Then there is the matter of attendance within the facilities themselves, and I believe the Japanese authorities and the IOC still have not made final decisions regarding the level of attendance at those venues because of the variations in the incident situation in Japan itself. Positivity rates in Japan are around 7%. So Japan has experienced an increase over the last number of, like everybody else, over a period of weeks and months. That has leveled off. It is not continuing to increase. And it is our hope, it is our hope for every country that that continues on a downward trend. And we will leave it to the authorities in Japan, who are highly competent, to decide what level of attendance could occur in the Olympics. I think the authorities have already decided that spectators and others will not be allowed come to the Olympics from abroad. So that's not something that's on the table at the moment. And then the issue will be the extent to which social mixing and socialising is allowed around the Olympic venues themselves. And again, I believe measures are being put in place for that, and decisions around that level of mixing will be made by the Japanese authorities in due course. And I've said the word mixing a number of times, and we've said this again and again with this virus. This virus transmits in places where people mix in higher density for prolonged periods of time. The aim of the protection around the athletes is to prevent that type of contact and mixing and close proximity, to create an environment of safety for the athletes, to create and maintain an environment of safety for everyone who attends, whatever that proportion is, and to create an environment of safety around the venues themselves. Some of those decisions cannot be made until closer to the event, because it will depend on the epidemiologic situation at that time. So it is not a failing at all on behalf of the organisers that they haven't made certain decisions, because those decisions can only be made on the basis of the epidemiologic parameters that pertain at that time. It is our hope that the Olympics can occur. Many other events, and we've seen sporting events and leagues run very, very safely over the last 6 months without spectators, with special bubbles and arrangements for athletes and for others, footballers and many, many others. It is a complex event. There are so many different events. There are so many different delegations. It is a test of logistics. It is a test of risk management. And we have confidence that the International Olympic Committee and the host city, Tokyo, and the government of Japan will make the right decisions regarding how best to manage the risks, and are working extremely hard right now to ensure that those risks are well managed. And we will leave any decisions regarding the extent to which the Olympics have attendance at venues and other decisions to them, as we believe they are applying a very, very systematic risk management approach to protect public health at this moment. And as needed, they will make the decisions that are needed based on the epidemiologic situation as we approach the July date.
Thank you very much, both, for this comprehensive view. And the next question goes to Donato Mancini from the Financial Times. Donato, please unmute yourself. Donato, can you hear us?
Hi. Yeah, I can. Can you?
Yes, now it's okay.
Sorry about that. So thanks for taking my question. On Sinopharm, could you give us a bit more detail on data for older patients, on efficacy? Have you received reassurances from the company on what they will do to ensure that there is enough data, or that they will generate enough data for older patients? Thank you so much.
Thank you very much, Donato. I'll look at Professor Alejandro Cravioto, the chair of the SAGE. Professor?
Thank you very much. I hope you can hear me well.
Very well.
We have the working group that SAGE has to review COVID vaccines made a thorough assessment of all the information regarding the Sinopharm vaccine and came to the conclusion that there is enough evidence of safety and the capacity of the vaccine to prevent severe disease or symptomatic and hospitalized cases up to 79%. We have information that the vaccine is useful for people above 18 years of age. And as the person asking the question said, the information we have for people over 60 is still very scarce. There is no reason to think that the vaccine would behave differently in this older age group. And in fact, in many countries in the world where the vaccine is already being used, this group has already been vaccinated. So in that sense, what we're encouraging is for the company or the people who are now in charge of the country programs to make sure that they have strong follow-up programs of safety and effectiveness of the use of this vaccine, especially in three groups of people: the over 60-year-olds, for which we have little information, people with comorbidities, which are essential as one of the main components for mortality, and of course the issue of pregnancy, for which there is also very small, there is no information for this vaccine. Once we have this information, then as with any other vaccine that SAGE has reviewed, we will look at the new evidence and make changes in our interim recommendations for this vaccine. But for now, after getting an EUL approval, we see no reason why this vaccine should not be recommended fully for use of people 18 years and above in a dosage of 2 doses from 2 to 3 weeks apart. Thank you very much.
Thank you very much, Professor Cravioto. And I'll look at Professor Arnaud Didier-Laurent, the chair of the TAG for Safety, Efficacy and Quality.
Thank you. So maybe I take the opportunity to explain a little bit what the TAG is doing, because I think that's the first time we actually have the opportunity to do this. So actually we are a group of independent experts that I'm honored to chair. And we are from different countries, different expertise in the world. And our role is to perform a benefit-risk assessment of COVID-19 candidate vaccines. And this is based on a report that is provided by the product evaluation team at WHO. So they're composed of regulatory experts of WHO, but also regulatory experts from different countries. So it is really a global effort, and we actually, in our assessment, we're particularly focusing on the specific needs of the low and middle income countries, including the way vaccines can be implemented. So in the context of these vaccines we're talking about, developed by the BIBP Sinopharm, we have reviewed data on quality of the vaccines, and that include outcome of an inspection of the manufacturing facilities. We also reviewed available data on efficacy and safety of the product, including the risk management plan, which is an important document because it's include the how we're going to monitor the performance of the vaccines after listing. So overall, and based on the robust assessment of this data and actually further clarification from the company, we concluded that the benefit-risk assessment was favorable for this inactivated COVID-19 BIBP vaccine. And therefore, we recommended actually this morning the listing of the vaccines for emergency use. To the question how this is going to be followed up, and actually, like all the vaccines we have been listing as part of our group work, and the TAG, and together with actually the WHO product evaluation group, we we requested additional studies that include clinical and real-world evidence from the company that committed to perform these studies. So, in fact, we're confident that we'll be able to generate data that the chairman of the SAGE mentioned in the future as soon as possible to actually allow a continuous evaluation of the vaccines because, in fact, the work doesn't stop after the listing because we continue reviewing data as they are provided by the manufacturers. And also I'd like to take the opportunity for, in behalf of the TAG members, first to thank my colleagues in the TAGs because we've been quite busy looking at this data, but also, more importantly, the works from the WHO experts and regulatory experts for the decision today. So thanks a lot.
Thank you very much, Professors Cravioto and Professor Didier-Laurent. Next question goes to Agnes Pereiro from the AFP. Agnes, please unmute yourself.
Yes. Hi, everybody. Thank you for taking my question. My question concerns children. There are some pharma companies that are seeking now national approval for vaccinating children. And in this situation, do you recommend vaccination for children? And do you think that all the children should be vaccinated, or only those who have certain medical conditions or comorbidities? Thank you.
Thank you very much, Agnes. And again, I'll look at Professor Ricardo Cravioto, the chair of SAGE.
So far, we have no vaccines that have been authorized for use either through the EUA that the FDA or the EMA give, or through the EUL listing that the WHO receives. We know that there's a dossier that is being reviewed concerning the 2 mRNA vaccines in use, one by Pfizer and one more Moderna, to lower the age group from 16-year-olds to 12-year-olds, but this is still pending. For the time being, we don't think that there is the vaccine or the actual need to start thinking of this age group as a priority group within the framework that SAGE has designed to see who should be vaccinated and in which sequence. We feel that in the case of countries that have enough supply of vaccine to cover the global population that they have, this type of decisions would have to be made by the local regulatory authorities and the local technical advisory groups. In the case of countries that do not have an ample supply of vaccine, then we suggest that they continue to follow the SAGE framework map that lists how the vaccines should be used in different age groups, looking at how we decrease the mortality and the severity of disease, which are the main outcomes that we're looking for at this time. I do not know if Dr. O'Brien would like to add something to this comment. Thank you.
Thank you, Professor Cravioto. Yes, indeed, we'll look at Dr. Kate O'Brien, Director of Immunization, Vaccines and Biologicals, to add on.
Yeah, let me just add a couple of things to that. We are aware that Canada did authorize the use of the Pfizer vaccine for 12 to 15-year-olds on Wednesday, the first country to provide such an authorization. And we do expect additional authorizations to come through for younger age groups below the age of 16 years of age, for which the Pfizer vaccine is already authorized. And we do expect those. We know that there are clinical trials that are ongoing for a number of products, and we expect from a regulatory perspective that there will be authorizations coming forward for those younger age groups. I do want to emphasize a couple of things. First of all, those authorizations do then provide a clearer pathway for children who have underlying medical conditions that put them at high risk of COVID outcomes. But I think the emphasis really needs to be on the prioritization of the highest priority age groups and those that are highest priority because of their exposures and because of their underlying medical conditions. And advancing to the use of vaccine, especially in younger children, and where the evidence about their role in transmission and certainly even younger children with even less transmission role, really before we've concluded the immunization of age groups and highest priority groups in every country around the world is laid out in the SAGE prioritization roadmap. And we would really like to reemphasize that the priority really needs to be getting vaccine to all countries in the world for the highest priority groups before we start advancing to groups that have much lower risk of disease. And when we have a supply that is adequately distributed in an equitable way so that every country has secured the implementation of vaccine for those highest priority groups, we very much welcome the use of vaccine, especially if it has a substantial impact on transmission.
Thank you very much, Dr. O'Brien. Next question goes to Isabel Sacco from EFE. Isabel, please unmute yourself.
Good afternoon, everyone. I would like to know what is the most recent WHO assessment on the variant identified in India, and that is responsible for the crisis that the country is living now. Do you know now if this variant is responsible for the current situation? Do you think that it should be considered as a variant of concern? And I would like to know if you consider that this variant is a risk, or there is a risk to spread to countries that have managed the pandemic lately. Thank you.
Thank you very much, Isabel. And Dr. Maria von Kerkhoff, please.
Thank you. Thank you very much for the question, and thank you for identifying this as the variant that was identified in India. This is the B1617, I believe, that you are referring to, which is indeed a virus variant, which is classified by WHO as a variant of interest at the global level. This is a variant that has several mutations that are of interest in terms of its ability to potentially cause increased transmissibility as well as reduced neutralization. We are, in fact, right now, the teams are meeting as we are here at this press conference to look at more detailed information from India as well as from other countries where this variant is also circulating. So part of your question was, is this variant being identified in other countries? And the answer is yes. Our ability to determine how much of this virus variant, the B1617, is circulating is largely dependent on the amount of genetic sequencing that is being done around the world. Now that is increasing, and we're seeing much more and better and more targeted use of sequencing, but it is still spotty around the world. The variant of interest, this B1617, is one virus variant that is circulating in India. There is also the B117, which is the virus variant that was identified first in the United Kingdom. This is classified as a variant of concern because it has demonstrated increased transmissibility, and this virus variant of concern has actually replaced other circulating strains in many countries around the world. So there's a combination of factors that are happening in India. We have the introduction of the B117, which has demonstrated increased transmissibility, this B1617, which does have some characteristics that suggest increased transmissibility. I say suggests right now because we're trying to pull together all of the information we have so that we can make a proper assessment, and the teams are doing that right now. We will also be discussing the B617 again with our virus evolution working group over the weekend. The other combination of factors associated with increased transmission in India has to do with social mixing and the number of contacts, the amount of mixing of individuals coming together, relaxation of some public health and social measures. It's a combination of factors. It isn't just one factor that is associated with increased transmission. The variants don't help. There are other virus variants that are circulating around the world that, of course, we're also looking at. So it's a combination of factors. But indeed, the 617 is one that we are looking at very, very carefully, looking at data that is coming directly from our colleagues in India who are studying this virus variant, as well as studies that are ongoing in other countries that have detected 617 in their populations. So we will have more information on that over the weekend and if at the latest on Monday. But we summarize everything we know about the virus variants in our weekly epidemiologic record, including the 617. So what we published on Tuesday on our website, I wish I had it, I would also hold it up in front of me, but if you don't look at those weekly epidemiologic updates, there's a wealth of information that's in there. And every week, we will describe what we know about the 3 variants of concern, the B117, the B1351, and the P1, as well as 7 variants of interest that we're tracking around the world. So it's a dynamic situation. The information is coming in fast and furious. We are working with scientists and partners around the world to consolidate our knowledge, the evidence that is coming online, even through preprints and through reports coming from countries, so that we can make a robust and a proper assessment about what we know, and then we can inform you accordingly.
And just maybe to add for emphasis there, that we're always concerned with variants, because variants can have, they're different, they have a slightly different structure, so they can have slightly different properties. And those properties can affect transmission, they can affect their virulence, or the way in which they cause disease, or the severity of the disease that they cause. And that's why we're all concerned globally to track and monitor those variants. So first of all, that tracking and monitoring is in place, but it's patchy, and we don't have that monitoring in some places. And again, there's an equity issue in this as well. We don't have equitable distribution of the capabilities or the technologies to track these viruses at the genomic level. And we're working very, very hard within WHO and with our partners to do that. We're working very hard with our partners in the ACT Accelerator and the Diagnostics Pillar and others to try and shift that balance. The Wellcome Trust and many others are involved. Beyond that, and Maria is absolutely correct when she says that these viruses change over time, but what we've seen in South Africa with the B1351, without vaccine, South Africa brought that variant pretty much under control by applying public health and social measures, by building a partnership with communities, by decreasing mixing and crowding, by investing in diagnostics and testing, in identifying clusters, and in bringing the disease under control. I'm not saying that you can stop the variants or even to stop completely the wild strain by just using those measures. My concern right now is that this virus has huge kinetic energy in some countries. It's got a massive force of infection. And we have got to slow that down, because it is been driven by both human behavior, by the emergence of variants, and many other factors. It's in some senses, we're pushing 3 different accelerators at the same time. And we expect to slow down. We're expecting the virus to slow down, and we're pushing the accelerators. We have got to stop pushing the accelerators on this virus. We need to vaccinate more people and protect the vulnerable. We need to reduce the risk of emergence of variants. And we need to, and I hate to say this because everyone has the hope in vaccines, and I have exactly the same hope, that we will eventually get to vaccination coverage rates that will protect everybody. But we're not there yet. We are simply not there yet. And what is driving these huge spikes in infection, it may be contributed to by variants, but what is driving it is proximity between people. It is crowding and mixing of people without protection, without hand washing, in poorly ventilated spaces, without wearing masks. And I know how hard that is in the context of some countries. But that is the brutal reality. And some countries now are at such a rate of infection that their health systems are back under severe pressure. We've seen the tragedy in India. We need to avoid that same tragedy occurring in other countries, and some other countries are heading in that direction. And we need to take action. We need to take the heat out. This pandemic is global, but this pandemic is acting very differently in different countries. Each country is having a unique experience, and I would advise every country to look at their data now and see where you are. Look at where you are in this fight, and some of you are not in a good place. And you need to protect your health system. You need to get your oxygen supply sorted out. You need to sort out your clinical triage. You need to make arrangements for home care, because some of you are not in a good position right now, and vaccines are not a solution right now. It's an awful thing to say, and it's a tragedy to say that in the context of what we see in vaccine equity and what Dr. Tedros is trying to do with Sumi and Mariangela Bruce and so many other partners to try and fix that. But we're not there yet. And we are going to have to stick to what we know works, shore up our health systems, drive down and suppress infection, and then accelerate the arrival of vaccines. I'm sorry to drive this home, because I think it triggers a question in me, because we keep coming back to why is this happening? Is it the variants? Is it this? Is it that? It's everything. It's everything. And the question is that happening? Yes. Is that a natural phenomenon? Yes. The real question is, what are we going to do about it? And some countries really need to take a look in the mirror in terms of what they're doing to drive infection rates down. Otherwise, our health systems in many countries will face real issues in the coming weeks and months.
Thank you very much for this. Next question goes to Ana Pinto, Folha de Sao Paulo. Ana, please unmute yourself.
Hi, good afternoon. I have a question about the Chinese vaccines listed for emergency use. I guess Dr. Mariangela Simão told us on Monday that along with Sinopharm, the Sinovac vaccine was also expected to be listed. until the end of this week. So I'd like to know if there is any news about the Sinovac vaccine. Thank you very much.
Thank you very much, Anna. Let me give this to Professor Arnaud Didier-Laurent, the chair of the TAG.
Yeah, thanks for the question. We have started to review the report from Sinovac. We have actually requested additional information to the manufacturer through a letter, so we're waiting for that answer. So again, it's part of our role to actually assess the data, and then we had reason to ask additional information that we hope to receive very soon to make a recommendation about this specific vaccine. Thank you.
Thank you very much. Next question goes to Christiane Oelrich from DPA. Christiane, please unmute yourself.
Thank you. I have a question on